the question we can always ask is, how does integration of physical agents enhance occupation? Actually, occupation and physical agent modalities are perfect together. To borrow from the old New Jersey advertisement for their tourist promotion, they would say, New Jersey and you perfect together. In this case, I say occupation and PAMS is perfect together. Many people become limited in their occupational performance by physical factors. Clearly, there are other factors involved, which we'll discuss. But physical factors are quite important to the outcome of many occupational interventions. One of the main ones we always encounter is pain control. People in pain have significant impacts on their occupation. When we get later as we move along through this seminar, we will discuss the impact of things like chronic pain, acute pain, referred pain, neuropathic pain, and how they impact on that person's occupational performance. Therefore, anything that we can do as occupational therapists to assist with someone's pain control activity or pain coping activities or coping skills will help that person improve occupational performance. If we cool a peripheral nerve, there is two things that occur. The first is we have a decrease in the synaptic transmission. So the neurotransmitters at the synapses actually move at a slower speed across the neurotransmitter junctions. And that, of course, results in diminished propagation of action potentials, which ultimately will result in a decrease in conduction velocity. And it is well documented that many nerves sustain a decrease in conduction velocity within 5 minutes of cooling. The clinical consideration here is when we apply cryotherapeutic interventions over exposed peripheral nerves. Let's considering the focus of this seminar is predominantly upper extremity indications. Let's consider where this might occur. It occurs in two places in the upper extremity. The first would be at the radial sensory nerve. So one of our common interventions for a simple thing like De Quervain syndrome is cross-friction massage or ice massage over the first dorsal compartment. This is in very close proximity to the dorsal radial sensory nerve and can result in neuropraxic issues for the radial sensory nerve. And this has been shown in the literature. Another nerve problem that occurs in the literature is when we apply a superficial cooling agent to the medial aspect of the elbow for, say, medial epicondylitis. We have to be very careful that we don't move into a posterior direction so that we don't stimulate or actually do a cryotherapeutic intervention to the ulnar nerve. There are documented cases of ulnar nerve axonoptomesis, which is essentially a significant nerve injury that requires axonal regeneration.
What do you do if you have someone who's complaining of severe burning at the tips when you put them in? Because I'm having severe burning right now.
If you have one of the reasons why you would have that is because if you notice how much longer it's taking for the paraffin to drain and drip off, it's because the paraffin is actually being caught underneath and it's pooling in the hand. So what I would do is, if in fact that happens, and you'll watch this is coming apart already, but you see because I have it up and under, it didn't come apart.
Right.
Okay, but you see how it wants to unwind? That's why it's vital that you have that underneath. Okay? If in fact the patient is complaining of significant pain, obviously you stop. You don't continue to dip them and tell them tough it out. that of course is not the right thing to do. We're now going to demonstrate for you a different application of ultrasound. To this point we used a continuous wave setting for collagen extensibility for a condition of stiffness of the shoulder. Now what we're going to do is we're going to look at tendinopathic lesions around the shoulder, and we're going to concern ourselves with supraspinatus tendons, the supraspinatus tendon here, and the bicep tendon, which is here. What we're going to have to do is show you proper positioning. The point of this is to show you the integration of positioning with the use of ultrasound. When I want to sonicate a supraspinatus tendon, I will have to reposition the shoulder so that I can get exposure of the supraspinatus tendon. To expose the supraspinatus tendon properly, one must internally rotate and extend the shoulder. This will move the supraspinatus tendon from a position under the acromion process to an anterior position. This allows easy identification of the supraspinatus tendon. It's right there. And one can sonicate this region in this position.